low that the lower end of the ureter is not easily found and not easily mobilized. So in such cases, ureter may need to be implanted directly to the bladder, forming a ureteroneocystostomy, which may be done with a Swas hitch or a Bowery flap created from the bladder if the defect is large. Sometimes in delayed conditions where the kidney is not functioning, a nephrectomy may be needed. In bladder injuries, in intraoperative identification, the bladder has to be properly dissected from all around and from the anterior vaginal wall. Complete demarcation of the rent is to be done, and any seemingly unviable portion of the bladder has to be removed completely so as to repair the bladder in the healthy, the two layers of the bladder should be totally healthy. Prolonged catheterization is required for at least 3 weeks, it is recommended. And in the immediate post-operative period, all efforts should be done to prevent any clot formation, as clot formation may lead to bladder filling up and sutures giving away. Anticholinergics may be used to stabilize the bladder, as these are the antispasmodic agents and they are seen to reduce the bladder contractions. So the suture healing is better with anticholinergics. In the post-operative diagnosis, if the patient is leaking urine and rent in the bladder is identified, first of all, what we do is put a catheter. We may put a catheter for up to 3 weeks time, because beyond 3 weeks epithelialization of the tract occurs, after which it will not heal, after which a fistula has to form. So there is no role of a catheter beyond 3 weeks. We have seen many patients with bladder injuries who have been kept on catheters for as long as 2 or 3 months at a stretch, but they are not going to heal that way. If a catheter is in place and still a urine leak is there, significant urine is leaking, the rent will not heal, because trickling of urine through the tract will prevent any healing of the tract. So epithelialization will occur and it will not heal. So in such cases, catheter is not recommended. Even if catheter was placed and it showed to decrease the urine leak, but if fistula has persisted and we are going for a repair after 3 months time, we should remove the catheter before 2 weeks prior to the surgery, because presence of a catheter leads to inflammation inside the bladder, leads to edema of the wall, and sutures that we will take at the time of repair may give way due to edema of the wall. Timing of repair is a concern. All the time the gynecologists, obstetricians are in panic mode when the bladder injury has occurred, and they want that how so early it is done, it is better. If this is diagnosed within 3 weeks of the surgery, it can be repaired very well. There is no problem in that. Otherwise, we should wait at least for 3 months. This has been the conventional teaching. Nowadays, studies have come with early repair of VVF, and they are showing somewhat comparable results, but still not all the studies have promised to have comparable results. So in such cases where we are in doubt, I think conventional teaching has to be followed, and we should wait for at least 3 months for the healing to be complete, fibrosis to be complete, and then the repair should be done. And then VVF, it usually the later stage patient presents with a VVF and it can be repaired. We all are very familiar with this thing. It can be done in trans-abdominal way if the VVF is lying in the supratrigonal portion of the bladder is high up. If the VVF is low down and including the bladder neck portion, it may be repaired from the transvaginal route as well. Nowadays, most commonly these surgeries are done with laparoscopy so as to reduce the patient's comorbidities. In dire situations where the bladder is not very well and there is too much scarring of the bladder due to the injury, or there is a large fistula that has occurred, so a urinary diversion may be needed. Thank you.
Thanks, sir. It was a really very comprehensive lecture. You rightly said we should do prevention of the injuries rather than having a sorry figure later on. But most of the time, sometimes it's not possible to prevent injuries, but it's better to diagnose in time, get the repair done on the table itself.
Exactly.
If we can diagnose it, because it's not a crime to do a injury. It's crime not to diagnose and not to manage it.
Yes.
That is not acceptable. And we also should take our multidisciplinary approach whenever we have a bladder injury or ureteric injury, and we should not shy away from taking help from our colleagues.
Yeah, just a minute. It was really very practical presentation, and we learned many things from this. And as she has said, that we should not be shy, or we should not be think that we have done the injury, because it says in the Jeffcott textbook of gynecology that nobody is a gynecologist until she has done ureteric injury. So we must, I mean, until we do difficult surgeries, I mean, we are not a gynecologist like that. So it was very nice lecture, and ureteric injury is usually inadvertent. Sometimes it is not seen during surgery. Bladder injury is open, I mean overt, we can see it. But then she is quite correct, we have to do early diagnosis, and then we should take help. That is very important. And in fact, we make secret friendship with the urologist over the phone, but secret.
Thank you, ma'am.
Yeah, this really shows the lunch was good. I see the energy back in the room. All right, we'll move forward. We got Dr. Anu Chawla. She'll be talking about pregnancy after PCOS. To do this honor, I'll be inviting our chairperson, Dr. Rajashri Purbe. Dr. Alka Pandey is not around. She is Dr. Alka Pandey. Dr. Mala, can I request you to please rejoin as a chairperson, if you're okay? Dr. Charu, do you suggest? Dr. Charu, please. Dr. Meeni? Yeah, I request you to please join us as chairperson. Now I request the chairperson to please invite our speaker. Dr. Shilpa Roy is here.
DNB, FMS, editor of the International Journal of the Human Reproductive Research and the Development, editor of the International Journal of Infertility and Sterility, and the chapter of the Bangladesh and Foxy Academy, coordinator of the 22-23, and joint secretary in Delhi ISR. Let us start.
Thank you so much, chairpersons, and all the respected audience who have taken time this late afternoon to be here for this lecture. So, because I only have 15 minutes, I actually have made a rather focused presentation, which would focus on mainly, we all know what is PCOS. I don't need to explain the problems in ART that PCOS can cause, but I want to focus on two important management points. One is the use of myo-inositol, or the second would be what is the latest up-to-date research work which promotes the use of progesterone. And can I ask in the audience if anyone has come across trials PROMISE and PRISM? Can you raise your hands if anyone is aware of these trials? So that makes it more worthwhile, because I'm going to spend more time on that. So there are two trials which I'm going to focus on because of very short time. One trial is PROMISE, the other trial is PRISM, and they are done in the, so I also have my private practice briefly, like 2-3 months in a year in London. So I'm associated with the this Tommy's Center, in which we are doing this research work. Along with my private practice in Delhi in IVF. So we know that in PCOS, mainly whenever we use any medications to enhance the outcome of the pregnancy, we basically are targeting three things. First is that we are targeting the hyperandrogenicity. The second is that we are targeting the insulin resistance, and the third is we're enhancing the ovulation and fertility of this patient. And obviously, we are mainly focusing on the fertility and the ART pregnancies of PCO patients here. But with the current management, there are some problems. So combined OC pills, progestins, insulin sensitizing agents, and statins are effective and also has metabolic and endocrine benefits, we know. However, their long-term effects on complications such as cardiovascular disease and diabetes are not known. So we don't know how much of benefit are we actually passing on by putting them on a long-term medications like these. And additionally, their effects on ovulation rates and hirsutism are very varied. So we all know that some patients don't respond to certain drugs and other patients do respond very well to a certain drug. And then we have newer products like N-acetylcysteine, which helps PCOS with minimal side effects. How the myoinositol is having a role in fertility is that it reduces the amount of the required recombinant FSH in the first place when we are doing IVF in these patients. It also improves the implantation rate, and then myoinositol administration in women undergoing. So basically, it's at the end of the day, it's the nature of this molecule is just a vitamin. So there's no harm. Is the first benefit. And it reduces the stimulation days, so it sensitizes the body to be able to respond the dose that the patient is given. And obviously I'm coming forward with along with the use of myoinositol plus progesterone in these two trials, and I'm going to showcase how it improves the oocyte and embryo quality. So the functions of myoinositol mainly are through the decrease of insulin resistance and increase of sensitivity, and then it also improves the glucose uterus. So now let's come to the main focus of my presentation, which is these two trials. So what is the evidence of effectiveness when we say we are going to use progesterone to give a better pregnancy outcome for these patients? So systemic reviews of RCTs, systemic reviews of high quality RCTs, and what is the evidence of safety? So systemic review for that. And what is the acceptability studies saying, and what is the cost effect? So these were the main questions which we put in front of us when we were doing this research in the University of Birmingham for these trials. And my one-time teacher, Professor Ari Kumaraswamy, he was the main principal investigator, and I was a helper in this study with the team in the University of Birmingham. So when we see, this is the meta-analysis, and how we read a meta-analysis is when you see the diamonds, when they are on the right side of the line, that means there's a statistically increased benefit of the use of progesterone. And here we are actually talking about the live birth after 34 weeks of gestation. And similarly, here you can see in the top that India actually was included in the patient population in which we actually collected data in 2014 in the Indian population, as well as other countries like Iran, UK, Italy, Malaysia, Turkey, and US. So these were the countries in which the study was conducted. How about the drug? So in the PROMISE trial, we checked congenital abnormalities alongside, and in the PRISM trial, we checked both the termination of pregnancy and congenital abnormalities, and here we are only talking of patients who have had poor obstetric outcome in the past. And when we say poor outcome, meaning more than one miscarriage. So this is published in 2020, that the study that I'm focusing on, PRISM, but then the practice is getting changed in many countries because of these trials, and that is why I'm focusing on this one. So again, in the British Journal of Obs and Gynec, Jan 2020, the cost effectiveness was highlighted very much as a prime focus when they talked about this study, because obviously when we speak about using something in NHS, we have to justify the funding aspect, because the healthcare system is funded by the government. So when we say less than 12 weeks of pregnancy had a bleeding, but there was no previous losses, in that case, it is okay if you don't add progesterone in such patients. However, if there's a threatened miscarriage in a case where more than one previous losses were present, then we switch on to using the micronized progesterone. Now, the number to treat was 25 and 8, and the relative risk was 1.09, so clearly in favor. There was a survey done by our team after we completed this study, in which we asked them that prior to the PRISM trial results, did you prescribe progesterone for threatened miscarriage? And only 12% said yes. And now the next slide will tell you how this trial has affected the practice in the country of UK. So following the PRISM trial results, when we did a survey that how many of you are now using the progesterone in the threatened miscarriage, it was actually 74%. So total role reversal happened because of this trial. So this was one of the most important trials which actually affected the practice, and especially in a country where government is funding the treatment. So that means that it really goes in favor of this. So again, this, as you see, that the diamond is going from left to the right of the midline, meaning that statistical significance is increasing when we are sequentially talking about patients with higher number of previous miscarriage. So if no previous miscarriage, there's no extra benefit. As you go 1 or 2 or 3 or 4, 5, 6 miscarriages, the benefit of progesterone actually shifts from the other side of, from left to the other side of the midline, which means that statistical significance is more for use of progesterone in a patient where with the higher order of miscarriage. Again, this was also published in one of my favorite journals, Fertility Sterility. If you follow this journal, probably you don't need to read anything else in fertility, is my conclusion over the past 14 years of my private IVF practice. So as we see that in this number of previous miscarriages, as they increase, the successful pregnancy increases along with the use of progesterone. So that means in a case of multiple miscarriages, probably it's the progesterone we should correct first. Now, what was the main difference between these two trials that we did? The first that we did was PROMISE, which was based on the prevention of miscarriage. And the second of the second trial, the PRISM, was the principle of this was how to rescue a threatened miscarriage. So the role of progesterone in recurrent miscarriages, enrichment via history of previous miscarriages, was mentioned in PROMISE trial, and then the rescue, which is basically the current pregnancy bleeding, was focused in the PRISM trial. Now, without going into too much of detail, I am going to just go to the conclusion. So the live birth after 24 weeks in cases of progesterone and placebo actually had the p-value of 0.45. And this is one of the case studies which we included. So she had 6 miscarriages. 32 years, I don't know, you call it old or young these days, so I don't want to comment on whether she was young or old. But then she requested progesterone because till that time the trial results were not out. She came to Birmingham where this trial was happening, and then she voluntarily became the part of this trial. And then obviously she had a live birth in this time, the first time ever in her life after 6 miscarriages. And because I personally came across this patient, I wanted to mention this, that it's very convincing when you first hand see a patient like that coming all the way, becoming a volunteer part of the trial and getting a live birth. So we see that now, okay, so this is again the same point highlighted. I'll just, again for the PRISM also I've mentioned the same thing, but I don't need to go into the detail of this. Sorry. So yes, so when there's no bleeding and there is no or 1 or 2 or 3 previous losses, in this trial we did this. So here we are talking about rescue of the threatened miscarriage. Earlier it was the prevention of the miscarriage. So we gave the standard care to one group, and the other group, higher order miscarriage more than 4, utrogestan was used. In cases of bleeding with no previous losses, you can take a screenshot or you can email me later, I'll tell you my email, I'm happy to send this presentation to you. So if it is a threatened miscarriage with more than 1 losses with bleeding at present, then again utrogestan was given. And the trial results already I've shared with you, so it was actually made to be a part of NICE guideline. That, you know, so there is, if you want to know more about what is happening, we are actually putting up this online live survey. So you can also use and then give us the feedback on this link for the survey, or you can go and see the updated outcome results that are continuously available on that link. So in the University of Birmingham, we have this American Statistician Association collaboration, in which basically this is how the whole data was analyzed. So it was actually a trial of a very high quality, in which the statistical interpretation was not done by doctors, to make it as less biased as possible. And then ASA guideline also, yeah, I'm just finishing now. So ASA guideline also has included this. So the PRISM and PROMISE trials have actually changed the practice in these countries. Basically, the conclusion was those flow charts, and something which changes our practice is definitely of interest to all of us. So I wanted to use my 15 minutes just for these two trials. Thank you very much. Thank you, everybody.
Hello. I
A
asked,
little bit.
your topic is pregnancy after PCOD.
Yeah, so
That
I've
means
focused
this
on
is the secondary PCOD that increases in our country nowadays. They, due to the sedentary habit or due to the low work load in the housework, and take the processed food. But this topic is changed.
So as you know that this is the session which is sponsored.
Oh.
So I was guided by for that, but then this is based on the proper study. So I only have 15 minutes, so I wanted to do justice rather than doing a lot of talking which you already know.
Thank
know.
you. And one question is that if the patient is lost 6 consecutive pregnancy, and when you want to start treatment, and how long you give the progesterone?
So progesterone definitely should be started in IVF cases on the day of egg collection itself, and then it should be continued at least till the placenta takes over. So generally the units, many units actually are doing minimum 8 to 10 weeks, and then tapering off after 12 weeks or by 12 weeks. But if you see the data, there is no evidence in any of the studies that we have that progesterone has any role after 2 weeks. So if you only want to follow the evidence, then you have to be brave enough to stop progesterone after 2 weeks of embryo transfer. But none of us is that brave enough. So out of fear, we continue till 10 to 12 weeks, but actual data says that there is no role of progesterone after 2 weeks of the egg collection. And the second thing that which is also in the literature but is not being practiced anywhere in the world is the use of GnRH agonist as the luteal phase support in these patients. There's a very solid evidence that there is definitely higher live birth when we use the GnRH agonist as the luteal phase support. And I can challenge that no one in the hall would have done that. So there are some literature points which are not still accepted in the practice out of fear, because we all love our patients. So we are afraid that we don't want to do something drastic. We don't want to be the first person to be doing that.
Yeah, I just wanted, just wanted to ask that in the PROMISE trial, there were a few patients which were taken, I believe around 2,000 patients were taken when there was a trial of progesterone. In the PROMISE trial, I'm talking about that. Then according to that trial, we could give progesterone till 12 weeks.
Yes.
This was the conclusion of the trial.
Yes. So this particular trial has used 12 weeks. But overall, if you see larger evidence in the data, most of the studies say that progesterone after 2 weeks is not required. The only solid evidence of role of progesterone is up to 2 weeks. Thank you very much.
Thanks to our speaker. Thanks to our speaker for such a wonderful and informative session. I would like to request Dr. Vanita Singh Madam to please join us on the dais for the felicitation. And Dr. Supriya Jaiswal. Up next, we have a quiz session, and for that, I would like to request Dr. Jyoti Agarwal, Dr. Bhavana Tiwari, and our expert, Dr. Zareen Rahman, to please join us on the dais.
Just a minute. Dr. Anu Chawla, she is very good friend of mine, and she's, one of the contestant. She will be coming for endometriosis committee, Foxy. So from my side, please support her. Okay. All the best. All the best. Anu.
So after this wonderful session, we are now excited. I can feel the excitement in the audience as well as the participants are here. Even we quiz masters are excited for the next session. So we are moving ahead for the quiz, Labourcon, on the topic fetal growth restriction for year 2023. So before we start the quiz, we had a preliminary round in which 20 teams participated day before on 7th of April. And out of those 20, all the teams were excellent, but out of those 20, we selected the best 4. And may I request the teams, as I call upon your name, please come near so that we can have the team selection first. So the first team was from AIIMS Patna, Dr. Kamlesh and Dr. Neha. Dr. Kamlesh and Dr. Neha from AIIMS Patna. The next team from Bhagalpur, Dr. Amrita Preetham and Dr. Shweta Saw. Dr. Amrita and Dr. Shweta, please come here. Third team from NMCH, Dr. Kaumudi Raj and Dr. Nagmi Khan. Kaumudi and Nagmi. And then from MGM Hospital, Patna, Dr. Jyoti Ranjan and Dr. Shikha. So we have 4 teams from 4 different places, from 4 different institutes. It was a wonderful preliminary round and they performed really well. Now before we move ahead, we'll have team selection. So before we move ahead, the quiz masters and experts. Now we were blessed to have Zareen ma'am as our expert, and she'll be joining us as the senior most quiz master from our side. Zareen ma'am will be one of the quiz master. Then we have Jyoti Agarwal ma'am, who has supported throughout in the presentation, making questions and encouraged me a lot. I'll be conducting few of the rounds, and I have the dynamic Dr. Khushbu from Mannat IVF to help me out. So we 4 will be the quiz masters. The 4 teams, Dr. Kamlesh, Dr. Amrita and Shweta, Dr. Kaumudi Nagmi, and Dr. Jyoti Ranjan and Dr. Shikha. Now for team selection, you can see the 4 balls moving on the screen. All the 4 teams. So based on your scoring in the prelims, I'll be giving you chance to select your choice. Okay? So the first team, Dr. Kamlesh and Dr. Neha, since they were the top scorers, so you'll get to select the ball. So please select the color of your choice. Which one, Dr. Kamlesh? Blue. So they selected blue. They are team D. So please take your seat, team D. Team D, Ames Patna. Khushbu, please mark it. Ames Patna, Team D. Dr. Amrita Preetham, Dr. Shweta from Bhagalpur. You will be selecting the next. So their choice is pink. Team B. Team B will be from Bhagalpur. Team B, Dr. Amrita and Dr. Shweta. Kaumudi and Nagmi from NMCH. Golden. Team C. Team C from NMCH, Khushbu. Team C, NMCH. So MGM, you don't have a choice. You have to choose the only left one, that is red, and you are Team A. Fine. This team selection has been done particularly so that there is no chances of any foul play in the quiz. Will be fair enough, and you cannot say that the questions were easy for Team A, difficult for Team C, etc. So this is how they got selected.
Lakshmi?
So before we start, we'll brief you about the rounds. There are 4 rounds. Round 1, direct questions will be taken by Zareen ma'am. Round 2, case-based scenario by Jyoti ma'am. Round 3, image-based will be taken by myself. And round 4 will be the rapid fire. So we'll begin with the first round, and I request Zareen ma'am to kindly take over this mic.
So good afternoon, all of you. And I wish all the best to all the teams. Hope they have geared up for the final round. It is not tough. Be cool and answer the questions. So first round is direct questions round, and rules: each team will get 1 question. 10 marks will be awarded for each correct answer. There is no pass, no negative marking, and 30 seconds for answering each question. Okay? So now we start. Huh? Yeah, teammates, yeah. There are questions? Okay. So the first question goes to Team A. When FGR is detected before 33 weeks, which one of the following is the most important determinant of perinatal survival? Gestational age, estimated fetal weight, umbilical artery Doppler indices, or CTG?
Gestational age.
Correct. So 10 marks goes to Team A. Now next question to Team B. What is pulsatility index in Doppler studies? Number 1, peak systolic velocity minus peak diastolic velocity upon mean velocity. B, peak systolic velocity minus minimal diastolic velocity upon mean velocity. C, mid systolic velocity minus minimal diastolic velocity by mean velocity. And D, peak systolic velocity minus mid diastolic velocity by mean velocity. Team B.
Ma'am, A.
A, it's wrong. No marks to Team B. No marks. Answer is B, peak systolic velocity minus minimal diastolic velocity by mean velocity. So it is Who is doing this? Yeah, okay. Third karo. Kare, pass. Next question to team C. What is resistance index in Doppler? A, mid systolic velocity minus end diastolic velocity by peak systolic velocity. B, peak systolic velocity minus mid diastolic velocity by peak systolic velocity. C, peak systolic velocity minus mid diastolic velocity by mean velocity. And D is peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. Team C.
Open your mic.
Mic
You're not
open.
audible.
She is correct. 10 marks goes to team C. It's peak systolic velocity minus end diastolic velocity by peak systolic velocity. So 10 marks, Khushbu. Now next question for team D. D. Delphi consensus based definition for early onset FGR are all except estimated fetal weight or AC less than 3rd percentile, CPR less than 5th percentile, umbilical artery with absent or reverse end diastolic volume, and D, estimated fetal weight or AC less than 10th percentile combined with umbilical artery pulsatility index more than 95th percentile. Correct. Answer is B, early onset, CPR is excluded, yes. So 10 marks again to team D.
The end of the first round. Now we have team A, C and D all with 10 points and team B with 0. Okay, Khushbu? Done. Now the second round starts.
Before that, we have a question for audience. This is for audience.
Audience question is there. Fetal assessment in managing IUGR cases include any of the following except A, cordocentesis, B, fetal karyotyping, C, maternal serum studies for evidence of seroconversion when there is suspicion of viral infection, and D is careful observation of early detection of preeclampsia. So except,
You have to raise your hand.
hand, stand up first. Okay. All three for A. Good. A is the correct answer.
Come have chocolate.
Where is the chocolate?
So with this, we come to an end of first round, and scores already ma'am has told. Team B has not opened their account, but all the 3 teams have plus 10. So next, I request Jyoti ma'am to take the next round. Ma'am, please.
Good luck to all the teams. Round 2. It is case-based scenarios. The rules are the same. Each team will get 1 case scenario followed by 1 question. Each question carries 10 marks. No pass, no negative markings. Team A. A 32-year-old pregnant woman with a history of previous small for age gestational baby. Her uterine artery Doppler shows notching at 22 weeks, which normalizes when repeated after 2 weeks. How will you continue her antenatal care? First, you continue as routine antenatal care. B, repeat uterine artery Doppler twice weekly. Start serial ultrasound measurements of biparietal diameter. And D, start serial ultrasound biometry and umbilical artery.
Will give
Team of Dr. Kaumudi Raj and Dr. Nagmi Khan. Come here. Sir. Ma'am. Ma'am, I invite Dr. Professor Shanti Roy, Padma Shri, a great feather in the Pox cap for giving out the prizes.
And I'm blessed to have Abha ma'am here. Ma'am has always been my guiding light for quizzing specially. She has always taught for this quiz. So ma'am, please join us on stage.
have to congratulate the team that organized it, and Bhana was such a strict quiz master. Had she been my external examiner, I would have just gone into a shutdown mode. Excellent. We really enjoyed the whole experience. Well done, Khushbu.
All right, last 10 seconds for clicking all the pictures. Quickly, we have next speaker waiting. So I request committee, quiz committee to please speed up. Yes. All right, I thank you all. Can we have a round of applause for all the quiz masters and all the team here? Thank you so much.
Hello. With this, we would like to proceed to our next session, which is a newborn session. And for that, I would like to request our chairpersons, Dr. Shipra Roy and Dr. Saroj Singh, to please join us on the dais. I would like to invite our first speaker, Dr. Rupesh, to please join us on the dais. And I would like to request our chairpersons to please introduce our speaker.
Good afternoon. I would like to invite Dr. Rupesh Kumar, DM Neonatology, to kindly come and deliver his talk. His talk is on newborn screening. Shall we start?
Yes. So thank you for giving me the opportunity, as we are coming to the last session and I have allotted 15 minutes and I have so many things to say, and I'll discuss not only bookish thing, I'll discuss what I experienced 10 years back when I was in postgraduate and what changes I have seen when I came after doing practice here after 10 years. So first, so I'll discuss under these following headings. So what is newborn screening? What is criteria? What disease should be covered? What primary and secondary disorders should be screened? And what is our Indian experience and what way forward? So what is newborn screening? This is universal screening to diagnose the affected infant and to give the appropriate treatment and clinical care, and to keep on the proper follow-up to see the clinical response. So what is needed for the screening program? So that disease should be specified. So what disease we should screen, and that can vary according to the scenario, according to the place to place. What is the facility of screening available in the local, what is the facility of screening is available? What is diagnosis and screening equipment is available? What treatment for disorder and what improvement outcomes should be available, and either that test is cost effective or not. So which disease should we screen? That disease should be public health problem. Screening is possible. Screening will improve the outcome and treatment available at reasonable cost. So the first screening was started by Robert Guthrie for phenylketonuria. So we have classified disease into three category, screening three category. High risk that need early diagnosis and treatment. In that include congenital adrenal hyperplasia, galactosemia, maple syrup urine disease, medium, long chain and very long chain coacyl dehydrogenase, citrullinemia and arginosuccinate aciduria, isovaleric aciduria, methylmalonic acidemia, and congenital cyanotic congenital heart disease. So that all these need urgent treatment. So immediately we should screen within 1 to 3 days. Moderate group that include biotinase deficiency, hypothyroidism, homocystinuria, phenylketonuria, glutaric acidemia, and beta-ketothironase deficiency. That treatment should be started by 1 to 3 weeks. In low group, that treatment can be started by 3 to 4 weeks. That includes cystic fibrosis, hemoglobin disorder, tyrosinemia, hydroxymethylglutaric aciduria, methyl carboxylase deficiency, carnitine uptake defect, hearing loss, and severe combined immunodeficiency disease. So what facility is required for the screening? So one is the blood sample and filter paper should be available. Screening equipment like pulse oximeter, autoacoustic emission, and BERA, and transcutaneous bilirubinometer. That is the equipment. Personal lab technician and nursing staff should be there, and shipment to the nodal lab, that courier service, and feedback, the person who can give the feedback and report, that should be prompt. So heel prick test for the blood disorder. So from where we can take sample, we can take one line, we can draw one line from the middle of the toe straight to the, from middle of the toe top to the bottom, and one line from the medial of the little finger, and middle part should be spared. So both lateral side, from there we can take sample, because there is a just subcutaneous tendon, subcutaneous bone is there, so that part we can avoid. And through the lancet we can prick. Before pricking we should warm the heel, and one macro drop of blood that should take that filter on the filter paper, that should completely cover. Here this is shown here, so that should be completely cover. And after taking the sample, we should give some time to keep the sample dry. That is for the heel prick test is for the, that is filter paper test is for the metabolic disorder, hemoglobinopathy, severe combined immunodeficiency, and cystic fibrosis, thyroid screening, and congenital adrenal hyperplasia for like 17-hydroxyprogesterone deficiency. So this is the simple spot check. So this is the first part, the first upper one. We can see this is the correct method of taking the sample. So whole sample should be covered, and after taking sample we should give some time so that should be dry, and that will be like chocolate brown color. So that we can give, so that is the proper sample collection. Other we can see all these 3, 4. So first one, that specimen quantity is less. Second is, that is, that is going outside the circle. In third, that is taken properly, but that was not given enough time to become dry, so that is red. A specimen appears super saturated, that is overcoming, that is, all are overlapped. Other fifth and sixth, serum quantity is more, that blood is less, so that is also not correct method. And in eighth situation, there is no blood. So that was for the blood. Now other is the point of care screening equipment. The first one is the pulse oximeter. The second one is the transcutaneous bilirubinometer. And third and fourth is the acoustic emission and the BERA for the hearing screening. So what equipment should be available for thyroid and 17-hydroxyprogesterone radioimmunoassay, for the organic acid, fatty acid, amino acid metabolism and lysosomal storage disorder, tandem mass spectroscopy, for hemoglobinopathy, liquid chromatography, for immunodeficiency and cystic fibrosis, PCR, and for the point of care digital microfluid. So this is the all equipment: tandem mass spectrophotometry, radioimmunoassay, PCR and genetics, and this is the digital microfluid for the serum bilirubin. This is silent room for the hearing screening. This is OAE screening. Does treatment improve outcome? So treatment available for all these conditions: congenital adrenal hyperplasia, hydrocortisone, galactosemia, galactose-free diet, maple syrup urine disease, liver transplantation, medium chain acyl dehydrogenase deficiency, carnitine and avoid fasting, citrullinemia and arginosuccinate aciduria, and very long chain and long chain acyl hydroxyacyl cohydrolase deficiency, avoid fasting, isovaleric acidemia, glycine and carnitine, and methylmalonic acidemia, thiamine, and congenital cyanotic heart disease, prostaglandin and surgery. In moderate group, biotin deficiency, which actually we are talking about which disease we can screen and we can treat. So biotinase deficiency, biotin we can give, hypothyroidism, thyroxine, homocystinuria, B6 and B12, phenylketonuria, diet modification, and glutaric acidemia, carnitine. Low group, cystic fibrosis में nutrition and enzyme we can supplement. Hemoglobin disorder, bone marrow transplantation is the treatment option. Tyrosinemia, liver transplant. Hydroxymethyl glutaric aciduria or multiple carboxylase deficiency, biotin we can supplement. Carnitine uptake defect में we can supplement carnitine. Hearing loss में 136 rule we will discuss later. And severe combined immunodeficiency, bone marrow is the treatment option. So either it is cost effective, so we can see the what is the incidence. Hypothyroidism incidence is 1:1000. If you want a screen, that 1% we can miss out of 1000. Congenital adrenal hyperplasia, again 1:25,000. Congenital cyanotic heart disease 3:1000. Hearing defect 3:1000. Jaundice 30:1000. Metabolic disorder 1:1000. Hemoglobinopathy 1:5000. And G6 PD deficiency is very high, 50 out of 1000. So what is harm of the screening? False positive rate is more, so there is a sometime chances of overdiagnosis. And false positivity rate is 5 to 7% for one metabolic problem. So we can give option to the parents. We are going for all these screening, and if they are refused, so we can do the proper documentation. Refusal signature we can obtain within 48 hours, and we should take we should keep in the medical record also. Refusal form should keep in the medical record and make certain that parents, guardian understand the risk of their child for refusing screening prior to take the signature. So this was the for a metabolic problem. Other was the universal eye screening in the newborn. ROP screening, we all know that is the retinopathy of the prematurity. The burden is 6 to 5% per 10,000 based on the population. This is the study in the South India. So as per the current estimate, total 3,20,000 blind children of less than 16 year in India. So major cause is cataract, ROP and vitamin A deficiency, and approximately half of the childhood blindness can be avoided or treated. Causes, so many causes, but here fifth cause, retinopathy of prematurity, I'll discuss. This is coming in the screening. So, whom to screen? All baby who has birth weight of less than 2 kg, of gestation of less than 34 week, and if baby born between 34 week to 36 week, but they have following risk factor like cardiorespiratory support, that need cardiorespiratory support, prolonged oxygen therapy, respiratory distress syndrome, chronic lung disease, fetal hemorrhage, blood transfusion, neonatal sepsis, exchange transfusion, IVH, apnea, or poor postnatal weight gain. All these babies should screen even if they are not premature, less than 34 week, either late preterm. So infant with unstable clinical course who are at high risk, all babies should be screened who have the stormy course in newborn. When to screen? So baby which born before 32 week of the gestation, we can screen at 2 to 3 week of the life, and baby who is born after 32 week, we can go after 4 week of the gestation. No, sorry, baby who was born less than 28 week of the gestation, we can screen at 2 to 3 week, and baby born after 28 week of gestation, we can screen after 4 week. Duration and frequency of screening. Initial screening examination will continue at least every 2 week until vascularization of the retina reaches the normal completion, until ROP regresses, or until ROP requiring treatment. Second is the congenital hypothyroidism. So this is the also newborn in universal newborn screening. So we can miss 5 to 8% of the affected infant can escape detection by the newborn screening. Suppose we are screening all neonate, even though we can miss 5 to 8%. What is the cause for that? A delayed elevation of the serum TSH, error in sampling, collection, or laboratory routine laboratory procedure, infant with TSH deficiency. In that case, if we are screening by 2 to 3 days of life within 24 hours, so in that 5 to 8% we can miss because of these following reasons. So what is normal cutoff of the TSH? Less than 24 week, less than 25 milli-unit per liter, 24 to 96 hour, 20 milli-unit per liter, and more than 96 hour, less than 15 milli-unit per liter. This is European Society of Pediatric Endocrinology update. So premature, just I have I have 2, 3. Okay, I am going fast. So all these report I am not. So sample collection. So how to collect sample within 42 to 72 hours of the age, and for the infant, all babies should screen for 48 to 72 hours of the age. For baby who are discharged prior to 48 hours of the age, a specimen should send prior to the discharge. And if infant get discharged before 24 hours, so again we can retest after 48 to 72 hours to minimize the risk of the false negative result. And if filter paper is not available, we can send the venous sample. Repeat screening can be done in low birth weight, very low birth weight neonate, ill preterm newborn admitted in an ICU, specimen collection within first 24 hours, and multiple birth, particularly if they have same-sex twin. Test should be repeated at 2 weeks of the age or 2 weeks after the previous test. So this is the guideline. So we can send sample at 42 to 72 hours of the life. If normal T4 and normal TSH, this is normal, repeat screen to monitor delayed TSH rise if they are preterm or sick neonate. Otherwise, there is no need to repeat. And if low T4 less than 10 microgram per deciliter or normal TSH, repeat test serum free T4 and TSH, and if there is low free T4, physiological immaturity versus central hypothyroidism, consider pituitary evaluation, and may be the most beneficial for the infant less than 27 week of the gestation. So congenital hypothyroidism, USA screen 4 million newborn screening for hypothyroidism per year. Incidence is 1:2000. And if there is no screening, So 20 to 30% of that have IQ of less than 30, and IQ point is 22 to 25 point lower in clinical hypothyroidism and 7 to 8% lower in subclinical hypothyroidism. Cost of screening is $30. For newborn screening cost for hypothyroidism is $5. In India, there is 850 rupees approx for congenital hypothyroidism, and for whole newborn screening, metabolic screening cost is approximately 4,000 rupees. So total US screening cost is $20 million per dollar they are spending in per annum. Pulse oximeter screening newborn. This is point of care pulse oximeter to detect the critical congenital heart disease. Incidence I am not going. So sensitivity of the pulse oximeter is different studies that shows from the 83 to 60 to 87%, that is varies from different study. And this is bedside test. Pulse oximeter screening test is the bedside test. So who should we screen? All preterm and term neonates should be screened by pulse oximeter. So early versus late. So difference in the sensitivity and specificity. So less than 24 hour, more than 24 hour. If less than 24 hour, we can screen because of the PDA is open. Sometime we can miss. So specificity more if we are doing early, 79.5%, and more than 24 hour, 73.6%. Sensitivity is almost equal in both cases, and false positive rate is less in more than 24 hour because PDA is closed at that time. So there is if PDA is open, so sometime we can miss. If PDA is closed after 24 hour, so false positive rate is less. Sight is preductal and postductal, either right hand or either feet. Either we can use foot alone or we can use right hand and either feet. So what is US and UK protocol? There is two protocol. So this is the protocol. What we can remember simply. So if there is less than 89% of the pulse oximeter reading is less than 89%, so we can measure repeatedly after 1 hour of interval 3 times, and if that is less than 89%, we can send to the cardiologist, and if this is more than 95%, directly we can, that is, so we can say this baby is okay. And if there is 90 to 94% after measurement of the 3 reading, so what we can do, we can keep for the clinical assessment. So one group more than 95%, that baby is okay. Okay, so other apart from that, we can do the hearing screening. Hearing screening mein there is 136 rule. 136 rule is that screening should done before 1 month of the age, and if it is not done, that should be done before 3 months of the age. And that intervention, suppose if we are miss within first month, we can do for all baby more than 34 week, we can screen within month. If miss, we can go within 3 months, and treatment should be started before 6 months. Otherwise, there is no beneficial effect. So this is 136 plan for the hearing screening. There are 2 methods, autoacoustic and BERA. So neonate, the first screening is OAE pass, that we keep in the follow-up. If fail, second OAE BERA pass, so follow-up. So again ABR fail, so second BERA we can go, and if there is fail, so we can go for the conventional BERA, and we can proceed for the ENT specialist. So jaundice, we all know this is the common problem. 60% of the term and 80% of the preterm newborn have the jaundice. So this is the Kramer rule. This is the clinical, although we are not using nowadays, but we can say 1, 2, 3, 4, 5. So clinically, based on that, in good light, we can assess how much is the approx serum bilirubin level. So we can see if there is 1, 5 to 7. So gradually, if this is coming in under 5, so this is the here, this is the 1, 2, 3, 5, this is leveled. So 1, 5 to 7, and as we gradually proceed further, palm and sole is icteric, means 13 to 15. So there is high level of the jaundice. So otherwise, if there is transcutaneous bilirubinometer, this is good enough until 15 milligram per deciliter. And if there is more than 15 gram per deciliter of the serum bilirubin, we can go for the venous sample. So approach. So take home message is the early diagnosis and treatment, genetic workup and genetic counseling we can do.
Thank you, Dr. Rupesh. That was very informative. And I think that's something we miss out other than jaundice and now thyroid screening. Other screenings are being missed out, especially the easier ones like hearing test or heel prick test. They should be done for all newborns. And it's really important to, like in Patna, I think most babies do get thyroid screening. But in smaller towns, even that is not being done.
Yes, that is
Other
also
than
very
for jaundice, there is no concept for screening. And as you've shown, what a difference it makes if the baby is hypothyroid and IQ loss of more than
Yes,
30.
yes.
That's criminal
Yes,
if we don't diagnose and treat.
And there is all these conditions, if we are not going for that, all these 44 in US, they are screening for 44 disease. In India, because of the cost and because of the availability of the equipment and the manpower, so there are 6 or 7 conditions. In NNF, that guideline they have given, they have categorized into 3 groups. Group A, Group B and Group C. So Group A, 4 or 5 conditions like thyroid, congenital adrenal hyperplasia, phenylketonuria and 1 condition I am missing. So these 4-5 conditions we can screen for the all neonate. And otherwise depends upon the how much the incidence like hemoglobinopathy and other that are more in the hilly area. So in that they have included according to region wise. They have National Neonatology Forum, they have categorized into 3 groups. So 4 or 5 condition: blood, hearing, ROP, jaundice, these 3-4 condition.
Thank you, Dr. Rupesh. Now I call upon the second speaker, Dr. Mishra from CARE India. Dr. Pankaj Mishra, please.
evening all. Thank you chairpersons and the esteemed guests, August gathering. Thank you all for giving me this opportunity, and I must thank the organizers of the Labourcon 2023 for giving this opportunity to tell about the public health implication of the newborn. Just now, this is the last session, I am the last speaker, I know the challenges of this last session. And basically the spectrum, the Dr. Rupesh just now talked about the newborn screening. This is the one side of the spectrum. The other side of the spectrum is that what is happening in the field and what academics is getting into the practice. This is the most important aspect that we have to cover. Dr. Rupesh just thought about the hypothyroidism, the adrenal hyperplasia, congenital heart diseases, retinopathy of prematurity, hearing screening. But is it going to the field? Many of the things are very important. The prevalence, the incidence is also very high. The screening is also very simple. Just we can do it. The institutional delivery in the public health aspect has increased from 10% now to more than 90%, many places. In the public health facility also had increased more than 50% of the institutional delivery is happening. But whether this institutional delivery is getting into the quality care that is being provided to the mother and the sick newborn, this is the most important aspect. What I am talking right now about the care of the small and sick newborn. What is the small and sick newborn? The small may not be sick. We may have the small one, maybe in terms of the weeks, maybe in terms of the birth weight, but may not be sick. And we can prevent this death also. So, and when the sick, what are the steps that we have to take? This is most important in the public health aspect. Now, this is the scenario in terms of the neonatal mortality, infant mortality, and the under 5 mortality. The Bihar has improved a lot in the last decades or so, and is better than the many of the states of the country also, and has improved in terms of the mortality rate of the under 5 mortality as well as the infant mortality. But still the neonatal mortality as well as the infant mortality, early neonatal mortality and the neonatal mortality is still higher than the national average. But we are contributing very high, because in terms of the population, what is the contribution of the Bihar in terms to the national is very high. Now we can see what is the importance of the neonatal period. What is the contribution of the mortality to the under 5 mortality. If we compare that, roughly around 7 out of the 10 under 5 death is happening in the first 4 weeks of the life. And it is most important. 25 million births are happening preterm. Out of them, 10% dies. And these deaths are preventable. Most of these deaths are due to the prematurity or the complication of the prematurity. How can we take care of this prematurity? Many of the times, we don't have any sickness. Other than the prematurity, maybe we have some sort of sepsis, congenital malformation, or the asphyxia. But the important aspect is the prematurity. We have to cover the prematurity, and we know how to screen. We are talking about the highest level of the retinopathy of prematurity, the hearing screening, hyperplasia, tender mass spectrometry, many more things. But if you go into the field, if you ask about the gestational age, everything depends upon the gestational age. It is the most difficult aspect to get the gestational age when we go beyond the Patna. Right now we discuss about the things that we are doing in the Patna. But many things, we have 38 districts in the Bihar. Right now we have 700 delivery points in the public health facility. More than 1,000 delivery points including the private facilities. But how many facilities are really getting into the, the other side of the room, we had the checklist that what are the things that we are providing into the normal delivery and for the cesarean. When we are going for the cesarean, what are the indication? Whether really we are doing or not. These are the things we will just examine. Right from the LMP, ultrasound, each and everything that we are available. But is it getting practically applicable into the field? And we are applying these things. This is really a challenge. Whether a baby is 28 weeks, 30 weeks, 32 weeks, 34 weeks, the action change. We have to basically imagine that what is the growth, IUGR, SGA or normal. These are the things that we have to basically discuss about. Now, this is the search study. Based on the search study, it was found that home-based newborn care, right from the delivery point to the birth to the 4 weeks, we can save roughly around 3 out of 4 births, basically suffering from the small, premature. So these are the things that we are basically discussing. 67.5% of the all neonatal deaths during pre-intervention phase occurred in the babies with body weight less than 2000 grams. Post-intervention, NMR reduced by 70%. The simple thing is that most supportive care. What are the supportive care? Delayed bathing, warmth, hygiene, extra breastfeeding. These are the supportive care that we will have to provide. Among the preterm LBW less than 2000 gram neonates, the reduction in mortality was greatest, 82%. For this group, supportive care was deemed responsible for 75% of the mortality impact. What to differentiate? Deaths from the contribution due to prematurity. Preterm birth as an underlying cause of death and LBW as an underlying cause of death. So their contribution to the NMR is likely to be fixed. Preterm birth is one of the most common cause of death in advanced health settings as well. This is the challenge even for the advanced setting, and we have to accept this fact. Now, we all are aware of the neonatal deaths, but what is the most important thing is that 3/4 of the neonates are dying due to complication of the prematurity and sickness. So how to basically identify the prematurity? This is the most important challenge that we have to address. The government of Bihar basically implemented that how to take care of these small newborn. We call them as a weak newborn, WNB. The baby which is a small but not sick. So what is this? Baby with, in the footnotes we can see that the baby with less than 2000 grams, baby born before 37 weeks and poor sucking from the time of birth. So this is the weak newborn but not sick. So we tried to basically, whosoever we delivered, we have to identify the weak newborn among all the newborn which is delivered. But the basic challenge is the calculation and recording of the gestational age with the help of digital application. We tried to basically build the capacity of the delivery points, the healthcare workers, to take care of that, how to identify based on the LMP, MCP card, as well as the digital tools that have been provided to them. Based on the LMP, you just record the EDD. So this is the thing that we tried our level best. The identification has improved, but it has not improved to the level that we are anticipating. Then ensure functional digital weighing machine. The digital weighing machine is also very important. It's not the digital. The important is that weighing machine is functional, is also calibrated, and the weight is recorded as per the record. So this is the most important aspect. Then promote proper weighing of the newborn, observation of the breastfeeding. This is the point. We are time and again we are talking about the immediate breastfeeding, exclusive breastfeeding, and then how it is getting, you have to observe and you have to teach the mother how to basically promote the breastfeeding. This is the most important, but mostly neglected. These are the important aspects that we have to take cover. And then early facility intervention and family. So we tried our level best. The government of Bihar, we work with the government of Bihar to identify and then initiate of the breastfeeding, dry cord care and the kangaroo mother care in the facility only. At the point of delivery, that we have to start the immediate breastfeeding, kangaroo mother care and dry cord care. And then the pre-discharge counseling of the mother and the attendant is also very important. That to identify the danger signs. What are the danger signs among the newborn, and then you have to take care of that. And then we track each and every week newborn, which is basically discharged from the facility to the home. That how to take care of the baby at the home. And we have this line list tracking on a daily basis. That what is happening in the first week of life. We are tracking with the frontline worker, we are tracking with the, and then if there is any danger sign, please refer the basic baby to the facility, to the nearest facility for the proper care. This is the impact you can see. This impact is from 2015 to 2021. 90% were informed at the facility that her child is weak. This is important that the mother knows that the child is weak. Not sick, but it's weak. And it has improved from baseline of 66% to 90%. And then 77% were counseled at the facility about the extra care. What are the extra care? This is just about the supportive care. You have to basically delay the bathing, provide them the warmth, skin to skin care, extra breastfeeding, and about the proper hygiene. This is the most important aspect. 60% informed after reaching home about the child, because once the baby is basically the mother is discharged from the facility and reach the home, this is also important that they basically follow that what is counseled at the facility. Someone visits the home and provide them the information. 58% were counseled on the extra care after this, and 7% were neither informed. Still we are missing. So 7% neither informed and nor it's been counseled. So this is the impact of the supportive care. What happened at facility? From the baseline 15%, it has improved to 47%. This is not a measure amount. 15%, because kangaroo mother care and the immediate past, we have also come up with the concept of immediate kangaroo mother care. We have to start the kangaroo mother care right from the birth. Right now we are saying that even the baby on the CPAP can be put on the immediate mother. Otherwise, if the mechanical ventilation is not required, the mother and the baby can be kept together as a couplet. So at the facility, at the home, from the baseline 100% to 62%. 48 hours delayed bathing after 48 hours and delayed bathing after 7 days of delivery. This is most important aspect. If the baby is small but not sick, if the bathing is delayed, this is also providing the supportive care and the this is the impact. This is basically birth weight adjusted neonatal mortality, and it has dropped from 55. This is the morbidity from 55 to 36 over a period of 5 years, and this you can see that the sample size is also very high. This is also the impact on the mortality. It has dropped down from 23% to roughly around 16%. So this drop is very significant if we identify the weak newborn at the point of care. This is, I'm skipping this slide, but this is also important in comparison to the Indian level, that what is the drop in the early neonatal mortality as well as the neonatal mortality and the under 5 mortality. Under 5 mortality in Bihar is better than the national level, but still the early neonatal mortality and the neonatal mortality is the important aspect that we have to work on. You can see that what is the percentage reduction in terms of the national average at the state average. The percentage reduction is also better than the Indian average, but our mortality rate is higher than the national average. That's why it is a better average, that better reduction. Now, these are the few last slides. Care and management of a small and sick newborn. What is important? We talked about the small, but there are percentage of baby which is also sick. And many of the small baby may turn into the sickness due to the prematurity. So identification of all preterm from facility to community, because roughly around 20% of the delivery is also happening at the home. So this is also very important that we have to identify the small babies as well as the sick. Intrapartum monitoring, care during the first golden minute at delivery points. I'm just giving you the example of the Bihar. We have set up, roughly in Bihar, I have set up SNCUs, the special newborn care unit at all the district hospitals. And we have the attached labor room. But the care at the delivery point can't be compromised with the special newborn, because you have to take care of the newborn if there is any sickness in the very first golden minute. The baby can't be transferred to the special newborn care unit, and this is message for all the gynecologists running their own clinic, because the newborn care corner should be inside the labor room, and we have to take care of the newborn then and there only. And this is most important, because the first golden minute can't be basically available outside the labor room. This is the point that we have to highlight. Quality of care of the preterm babies and babies with the birth weight less than 1800 grams with effective use of equipment available. We have multiple equipment, but the care providers doesn't know how to run these equipment. Mother and newborn always kept together in the clinical practice. I'm talking about the immediate care, kangaroo mother care. I'm just giving an example. Roughly around, I think about 12 months back, a lady called Bandana delivered her female baby at 31 weeks of gestation. The weight was roughly around 1280 grams. Baby was immediately handed over to the mother, but just take away and then put on the CPAP. Was put on the CPAP, then also provided the warm and wool blanket. And the third thing was that immediately a neonatologist come and transfer the baby to the mother. For the immediate kangaroo mother care, baby was availing the facility of the CPAP, also having the blanket and also put on the IV fluid. Immediately the mother also expressed some milk, very small amount, 7 ml of milk was also given. And after a gap of 48 to 72 hours, the baby was also handed over to the mother, was discharged with only the supportive care, and after a gap of 9 months, the baby is normal to any of the normal baby, and roughly around right now they are basically coping with all the normal development. So this is the supportive care that we are providing, and the immediate kangaroo mother care is the answer for all the small baby but not the sick. Mother and newborn must be kept together. This is the message that I just want to, if any sickness, even if no mechanical ventilation is required, the mother and newborn must be kept with as a couplet care. Apprehension about the, many times we thought about that the nosocomial infection may happen, but this is only our apprehension. If we practice as per protocol, the nosocomial infection can also be controlled. Equipment availability and the maintenance like oxygen supply is also has to, skill to operate CPAP. CPAP is been supplied to all the SNCUs, but how to run the CPAP? How to basically make the facility basically operable to run the CPAP. We have the oxygen supply, but we don't have the air supply. To basically to supplement the air compressor, and we have to blend the air on oxygen also. So these are the things that we have to work upon. Now this is the,
Just summarize.
yeah. So these are the basically 2 or 3 points that we already have. The kangaroo mother care less than 2 kg, corticosteroid, antibiotics for the PROM, CPAP for the respiratory distress syndrome and the surfactant. We have the individual impact, but if we apply all the intervention as per the requirement, the impact is really good, and we can have this. So this is all about the small and sick newborn. Government of Bihar is also trying to improve, and perhaps with the combination of the private practitioner, we can further improve the things. So this is all about that. Thank you for giving me this opportunity.
Thank you, Dr. Mishra, for this very nice, interesting talk. I have just to say that every woman has got the right to know about the health of a child, and the health begins right from birth. When the baby is born, it should be cared for, it should be immediately, cord should be there, clamped about a minute after, the baby should be placed on the chest wall, or rather you can say a kangaroo care is needed for the newborn child. And then we also would like to know which babies are weak. The weak babies are those who are born before term, preterm babies, and also those who are less than 2,000 grams, who are poor at breastfeeding. So these babies should be identified, and they need special care. And sometimes the baby is more serious, then they have to be transferred to the special care units. And this is all what I have to say. I think we have had enough. Thank you very much.
Thank you. All the interventions that you mentioned, delayed bathing and everything, they are zero-cost interventions. Yes. So that can be done at any place and by everyone, and that makes such a difference to the well-being of the baby. So thank you for bringing that to light. Thank you very much.